Hello, my name is Jennifer Stransko, and I'm the Physician Engagement Associate for MAVEN Project. Thank you all for joining us today and our friends at El Rio FNP Residency Program for hosting today's session, How to Assess Cardiac Concerns in Children and Adolescents in Primary Care Clinics with Dr. Claude Rogé. After Dr. Claude Rogé completed his training at UCSF, he was hired at Kaiser Northern California. He started the regional ECHO lab at Kaiser San Francisco and practiced pediatric cardiology at Santa Clara in San Jose. Dr. Rogé also stayed on the clinical faculty at UCSF, where he worked in the pediatric cardiac laboratory 1 day a week. He was also a clinical assistant professor of pediatrics at Stanford University. He retired in December 2012, and he was asked to be the medical director for School Health Clinics of Santa Clara County, a FQHC serving the underserved population in Santa Clara County. Dr. Rogé started at SHC in January 2013. In addition to his administrative role, he still sees children presenting with the most common cardiac conditions in his clinics and reads EKGs. Dr. Rogé is also a volunteer at Santa Clara Valley Medical Center, where he attends occasional pediatric cardiology clinics and covers for the regular pediatric cardiologist when out of town. And with that, Dr. Rogé, it's all yours.
Good morning, everyone, and Happy New Year. So we are going to start the year by going over cardiac concerns in children and adolescents in the primary care settings. Here I have no disclosure here, no financial interest. A few things that will be available for you if you want to read. The objective, as a primary care provider, we will review some of the situations when you need to rule out heart disease in children. And we'll go over when you do a sports physical, when you hear a heart murmur, or when the patient has hypertension. And very briefly, we will go over exactly also on what to do when patients present with symptoms such as chest pain, palpitation, and syncope. And so in order to rule out heart disease, it is necessary to obtain a careful family history, looking for genetically transmitted diseases. Then take a careful history of the events surrounding the apparition of symptoms. Then do a complete cardiac physical evaluation and occasionally order appropriate tests. And then finally, as a primary care provider, you would have to decide if it is appropriate to refer to pediatric cardiology for further workup. Most of the time, you will conclude that there is no heart disease, and you would have to reassure the parents. And we will review that this can be a challenge. Okay, I don't go over that again. Jennifer did. This is what we're going to review today, the introduction, sports physical, cardiac evaluation in the primary care physician during their routine work in the clinic. So primary care clinicians have an essential part in the detection of heart disease in children, and we will go over that. But the goal of this introduction to pediatric cardiology is to make primary care providers better equipped to evaluate the child. So again, one is a PCP in the role of detecting heart disease in children. And there will be a few circumstances here when doing a sports physical, or when the PCP detects a heart murmur or hypertension during a routine visit, or when evaluating a child with quote-unquote cardiac symptoms. So let's go first over sports physicals. So sports physicals are mandated in nearly every organized athletic programs and are performed with the intent of identifying any condition that may preclude an athlete from safely participating in athletic events. And I'm going to go over the pre-participation physical evaluation, and that has been developed by all the organizations that basically are involved with sports in children, and you can see also in adults here. And I'm going to use the form that is prepared by the American Academy of Pediatrics, but it depends in your, when you work, you may get forms already sent to you by the school, the high school. Some high school, they have their own forms and they want you to sign those forms. But yet they are usually based on those medical societies who put together those forms. And basically, this is again the pediatric from the American Academy of Pediatrics. There are two forms. In blue here are the forms that are completed by the patients. There are multiple questions, and this is available in English and Spanish. And then there is a form that is a physical examination form that's completed by the physician, the clinician. And then that's what you sign and that you give back to the patient so they can show to their school or their sports organization that they are okay to participate in sports. So if you look at the history form, there are lots of questions about heart health, okay? Have you ever passed out or nearly passed out during or after exercise? That's a red flag always. Again, have you had discomfort, pain, tightness, or pressure in your chest during exercise? Again, symptoms during exercise is always a red flag, okay? Does your heart ever race, flutter in your chest, or skip beats during exercise? Has your doctor ever told you that you have a heart problem? So that will be a past medical history here. And have you ever done an electrocardiogram or echocardiogram? So that would have been, one step further, even in the evaluation here. Again, another symptoms, lightheaded or shortness of breath during exercise. And then he goes over the family history. Has any family member or relative died of heart problems or had unexplained sudden death before age 35? So early heart disease or cardiac death, sudden death, that's really a red flag as well. And then here, it gives the name of genetic heart problems. And, even you are not supposed to know all these things. Many of them are very rare. But if, a patient has a father or grandfather or grandmother with one of these conditions, they may have heard those names. They may have heard of long QT. They may have heard of Brugada syndrome in that context, or polymorphic ventricular tachycardia. Even though that sounds very esoteric, of course, and for most people, they would not know what you are talking about. But again, if someone in the family died from all those conditions, probably they would be aware of it. And again, same if they had a pacemaker or a defibrillator before age of 35. And then there are, of course, the questions involving all other organs, but we are focusing today on the heart. And the form that you completed, which has to do with the physical exam, also has some aspects connected to the heart. So the appearance here is mainly focusing on the MAVEN stigmata. So when you see people with kyphoscoliosis, high arch palate, pectus excavatum, arythnodactyly, hyperlaxity, that's usually with the thumb sign, you can they can go way past the edge of the hand when they do this, or if they have myopia, mitral valve prolapse, or aortic insufficiency. So that would be definitely red flags here. And then when you do the exam, of course, if you hear a murmur, and we will go over that in some more details. So the focus for the PCP is to rule out the rare cardiac condition that can cause sudden cardiac death during exercise. So this is actually very rare, okay? So I don't want you to lose sleep and think that you are missing every day something, because this is very rare. If you look at the cause of accidental death per year in adolescents in the US, you know, sudden cardiac death, you can see, is half as frequent as being struck by lightning. So it gives you kind of an idea how rare it is. And if you see the difference with car accidents, you know, that's huge, okay? And if you put all the cause of death in children and adolescents, you can see heart disease doesn't go very high. There are lots of other conditions that cause heart disease and death in children before heart disease. Now, what are those causes of sudden death in competitive athletes? And this is an old study, but it's comprehensive, but also to point out it is involving athletes less than 35 years of age. So the most common one is hypertrophic cardiomyopathy. Basically, half of them are from that. So that would be a focus when you do a sports physical, who that patients have hypertrophic cardiomyopathy. The other one are more unusual, and that would be coronary abnormalities or heart disease. So as you get older, there would be coronary heart disease. In children, that would be mainly coronary artery abnormality. And I mentioned before, MAVEN, that's what's caused rupture aorta, and that you can see that's less frequent, but still on top. So we'll review these three conditions: hypertrophic cardiomyopathy, coronary artery abnormalities, and then rupture aorta in the context of Marfan syndrome. Okay. So is there a way for us in primary care clinics to suspect this condition and prevent a sudden death? So let's review them. Hypertrophic cardiomyopathy, again, is an autosomal dominant condition, and it involves this organization of the sarcomere. In the normal people, you have a very perfectly aligned, the thin and thick myofilament, and they intertwine like this during contraction. And in hypertrophic cardiomyopathy, it is totally disorganized. It's a bizarre shape. There is disarray and multiple pathological features, including myocyte hypertrophy, myocyte disarray, interstitial fibrosis. So this is, on the microscope, what you see, very different from the more organized pattern that you see in normal heart. So again, it is an autosomal dominant, which means that if someone has, he had a first-degree relative affected, the problem with that is that you have very valuable penetrance. That means that, you know, you can have people who die suddenly when they are 25 or 30, a relative, or who is diagnosed early because he had some symptoms, you got evaluated and the diagnosis was made. But you could also have people who have hypertrophic cardiomyopathy, they have no symptoms, and they get diagnosed, you know, when they are 60 or 70 because they go for elective surgery for their knee or hips, and for some reason the anesthesiologist wants to have an electrocardiogram and find out there is an abnormal electrocardiogram. They do an echocardiogram and, oh, you have hypertrophic cardiomyopathy. So there is variable penetrance. So, you know, it's not always obvious. Now, it is quite frequent. You see, 1 in 500 people have that gene. So it is actually more frequent than Down syndrome. So if in your practice you take care of children with Down syndrome, well, you should have at least as many patients with hypertrophic cardiomyopathy. So it's something to keep in mind. It's very frequent. Now, how do you detect it? Again, the problem, lots of people are asymptomatic, but if anyone present with chest pain, palpitations, or fainting with exercise, that should ring a bell for you. Could it be hypertrophic cardiomyopathy? It's not always going to be the case, but you need to exclude it. Now, when you do a physical exam, you may hear a murmur. Now, there is no guarantee you are always going to hear a murmur in hypertrophic cardiomyopathy. It depends on the severity of the condition. But if you hear the murmur, there is something very specific that you have to remember here, is that it is louder in the sitting or standing position than in the supine position. And that's actually the reverse of what you hear in innocent heart murmurs. In innocent heart murmur, they are louder in the lying down, and then they get softer when they stand up. So it is a reverse in hypertrophic cardiomyopathy. And if you have really a patient either with a family history of a systolic heart murmur like this, that's louder when he's sitting or standing, you are going to get an EKG for sure. And the EKG usually, I mean, is, I would say 98% of the time is going to be abnormal. So that would be a good way to detect hypertrophic cardiomyopathy. And what do you see? You can see those deep Q waves here in the left precordial leads. And then not on this case, it's not very clear, but you can have also ST segment abnormalities. I don't know if you have any questions about hypertrophic cardiomyopathy before I go to the next one. Okay. So the next one to rule out are coronary artery abnormalities in children. It's more unusual than the hypertrophic cardiomyopathy, but it is second, more frequent. Now, as you know, normally the left coronary artery comes from the left coronary sinus. The right coronary artery comes from the right coronary sinus. And the pulmonary artery is usually in front of the aorta, of the pulmonary, the aortic valve. Okay, so you can see in those drawings here, you have multiple types of abnormal coronary origin. It could be from the right cusp. It could be from it could be from the left, but it could be an abnormal course. For instance, you could have you can see here an abnormal course of the right coronary artery between the two great arteries. So there are multiple options. Briefly, I want to mention also, even though acquired heart coronary heart disease is going to be very rare in children, if you take care of young adults who are going to participate in sports, that is going to be more frequent. The most frequent is going to be the atherosclerotic fund, but unfortunately, we see more and more of the drug-induced cases, and we'll go over that a little bit. So how do you suspect these conditions? Well, family history of coronary heart disease. So usually, again, someone with a heart problem in an early age, that would be a red flag. Again, I will mention before, chest pain, syncope with exercise, that's a big red flag. And in any of these circumstances, you will get an EKG and it's an abnormal ECG. Now, again, you may do this test depending on what you get from the history. You know, if you get someone who is saying he's taking some drugs, you know, you may want to do a drug screening. Troponin is, you know, if you suspect, a heart attack, so you would do that one too. And there are some references here. The third most common cause for sudden cardiac death in sports is from rupture aorta. And the most common reason for that is MAVEN syndrome. And again, we went over it a little bit. MAVEN syndrome is an autosomal dominant condition, and it is much less frequent than stem cell, less frequent than hypertrophic cardiomyopathy, but still it is the most frequent connective tissue disorder. And it is usually fairly easy to suspect it because you will have all the signs, kyphoscoliosis, high arch palate, pectus excavatum, arachnodactyly, hyperlaxity, myopathy, prolapse, and so forth and so on. So if you suspect that, then is further evaluation. Now, there are other causes of aortic root dilatation. The most common one is bicuspid aortic valve. But bicuspid aortic valve, you know, you will hear a click, you will find out, you know, if you get a chest X-ray or an echocardiogram, but at least in children, bicuspid aortic valve is very, very rare to cause aortic rupture, okay? So that's not really a cause of aortic rupture in children. As people get older, that could become a problem, but again, and the same with atherosclerosis, okay? Eventually, it could cause some aortic, some rupture of the aorta, but that very, very rarely is going to occur in children. Even in young adults, that would be very, very unusual. So in conclusion, for sports physical, I definitely I recommend for you to use one of the pre-participation evaluation forms. And probably if you do this for the schools, the patients may come with one. Otherwise, you can find them online. I mentioned the American Academy of Pediatrics, but all these other organizations will have it. And again, you will suspect a heart problem if the patient has symptoms with exercise, or you have suspicious clinical findings. Again, heart murmur, louder in the standing position, MAVEN phenotype, and in those cases, further cardiac evaluation is recommended. And the first step is usually an electrocardiogram. If you have suspicion, then you refer to pediatric cardiology before they do sports physical. Okay. So unless you have questions, we go to the next topic here. We go first heart murmur and then hypertension. So this is a case here of Juan, who is a healthy 5-year-old boy, and you have been following him for well child care since he was born. And for the first time, when he's 5 years old, you hear a musical systolic ejection murmur at the left sternal border in the supine position. So what do you do next? Well, it's very important to take a minute and review the family history. So is there any history of early cardiac disease? No. Okay, good. You review the past medical history. Any cardiac symptoms? You review the growth or normal growth. Good. And then you go back again over the physical exam and you do it very, very thoroughly. So you see if there is a good capillary refill. Okay, good. Good capillary, no evidence of cyanosis. You repeat the oxygen saturation, normal. Okay, good. You take the pulses in all extremities. So what I recommend you always do, you take the pulse at both arms at the same time to make sure there is no discrepancy and one of them is delayed or something like that. And then you take the pulse at one arm and one leg at the same time. Okay? And then you, of course, you are going to take the blood pressure, and you are going to take the blood pressure in both arms. And then again, you are going to take the blood pressure. If there is any suspicion, there is pressure difference between the arm and the legs in one arm and in one leg. And then you are going to repeat auscultation. So you listen carefully. S1 sounds normal to you. Okay, you go at the base here and you listen to S2. It is split. You hear at the base, and you hear the splitting in inspiration only. Oh, that sounds good. And then you listen for extra sound. No click, no S3, no S4. And then you listen again to the heart murmur, and it really sounds like a musical heart murmur, like a twanging sound, like made by a twanging piece of string, tense string. And you listen in different position, and you find out it is actually louder in the supine position at the left sternal border, and you cannot hear it in the sitting and the standing position. And then you listen for transmission. Do you hear that murmur in the back, in the neck, in the axilla? No. Okay, well, that's good. Do you hear in diastole? So you focus on the heart sounds, and then in diastole, no. Okay, good. And then, of course, you are going to listen to the lungs. Is this normal? And then you feel for organomegaly, no organomegaly, all that sounds normal. You also, of course, after you do that thorough physical examination, say, well, maybe I should get a hemoglobin. And in most clinics, you can do that right then. So you make sure he's not anemic. Someone who is anemic is going to have a murmur. And, you know, that is reassuring if the murmur is no. So what do you do next? Okay. Well, in your head, you know, you won't have time to go to your restroom and take off your clothes and think for hours. But, you know, basically, something is going to come to your mind, and it's going to say, I am missing a heart defect here. So I am listing here the most frequent cardiac conditions, and that was from Atlanta. And in green here, I put the heart defect that you as a primary care provider are likely to be the first one to detect, okay? The other one most likely would already have been detected before you see the patients, okay? So if we go very briefly over all those, the most common cardiac conditions here, ventricular septal defect. Why is not detected in utero? Well, it depends, you know, I mean, even if someone has a very thorough fetal evaluation, you know, like even a fetal echocardiogram, a VSD may be missed because especially the muscular ventricular septal defect will not be detected because there is no shunting in utero. The pressure between the right and left ventricle are the same. So you will see blood going across the defect. Now, you know, if it is a good prenatal fetal echocardiogram by experts, they will probably detect perimembranous and supracrystal VSDs because, you know, if they are really expert in that. Someone doing a routine obstetrical ultrasound probably will not detect any VSDs. But you say, well, why would that be detected at birth? You know, it is a loud murmur usually. Well, not at birth, because again, at birth, you have some pulmonary hypertension, and that prevents a left to right shunt. You don't have the left to right shunt at birth. And even a healthy full-term baby, he may take, you know, 24, 48 hours before the pressure drops enough that you can start hearing the murmur. So the child may have gone home with no murmurs. So that doesn't mean that, it could be that the child has a VSD, was not diagnosed. But what is typical about VSD is that it is a pansystolic murmur. You hear it throughout systole, okay? So it's usually a harsh pansystolic murmur. And that's not what you heard on that case. You heard a normal, musical sound that is short. It disappears when the patient is standing up. That wouldn't be the case with VSD. You would still hear it. So VSD is excluded. Now, ASD, again, very common heart defect, but that is not going to be detected in utero because everyone has a PFO, unless it's a huge ASD, like a primum, ostium primum, a large ostium primum ASD is going to be detected in utero with a fetal echocardiogram. But most secondary meteoroceptor defects are not going to be detected because patients have a PFO, they have a big shunt going through the defect in utero. And so, I'm sorry, I'm sorry, I cannot take your call. The ASD usually again will not be detected in utero, will not be detected after birth as well, because again there is pulmonary hypertension and no left to right shunt. And so that could be you, the first person detecting that. But for ASD, you will have a prominent right ventricular impulse. When you put your hand here over the chest, you will feel a strong beat, and you don't see that in innocent heart murmur. And then, because you are concentrating on ASD, you are going to concentrate on the second heart sound. And in ASD, it is widely split, and it doesn't move with respiration. In the case you were listening to, it was moving with respiration. Okay, so, it's unlikely to be an ASD. Now, PS, again, severe PS is going to be detected in utero, but mild PS, you may be the one detecting it. Well, that is usually a murmur at the base. It is usually transmitted to the back, and often you hear a systolic ejection clip. You didn't hear any of that, so you said, okay, that's not ASD. Coarctation of the aorta. Well, that also can be missed, in the neonatal period often, because there is a PDA open, and even if there is a severe coarct, it may not be detected. But again, you check the pulse, you check the blood pressure, and there is no pressure difference, the good pulse in the legs, it's not coarct. And in coarct, the murmur is in the back. You heard the murmur in front. Murmur was also on the side. You didn't hear that much on the side. Okay. Now, PDA, of course, every newborn is going to have a PDA, so it's not going to be detected in the nursery. So but usually PDA, it is going to be a continuous murmur. Okay. And you did not hear a continuous murmur, so you don't have to worry that you missed a PDA. The last one to think about is aortic stenosis. Again, a mild aortic stenosis will not be detected in the nursery. It may be the first one, but usually you will have a murmur at the base transmitted to the neck, and that murmur you may hear a click at the apex also. So you didn't hear any of that, so you don't suspect that. Okay, so this is when I ask you a question. What do you do next? You have done the physical, you went through everything in your mind that and you feel pretty confident it is an innocent murmur. What do you do next? You reassure the child and the parents, and you say one has a normal heart sound. We often hear it in healthy children. We call it an innocent heart murmur. Or second option, you order an ECG. Or third option, you refer to pediatric cardiology for further evaluation. So why don't you either write in the chat, or maybe if you are in a group here, someone can take the sample, what everyone is answering, and tell Jennifer, who can let me know what you would do in a case like this. Jennifer, anyone putting anything in the chat or any answer?
Yes, number 1.
Ah, well, that's very good. That's it. You already know it. That's good. That's the right thing to do. Even though, you know, the other, there is nothing wrong with the other ones. It depends on a number of things. How certain you are of your findings, how comfortable you are, because some people are not very comfortable, listening to murmurs. I mean, I have dealt with excellent pediatricians who are not comfortable listening to murmurs, and some pediatricians who are so, they were great at that, so, it depends on your quality. But if you are comfortable, if you have done it several times, that's the right thing to do. Order an ECG is not a bad idea, except that often you have false positive. And if you have false positive, then you have to refer to cardiology, and that increases the anxiety. So again, most of the time it's going to be okay to order an ECG, but occasionally you get a false positive. And refer to pediatric cardiology for further evaluation. I mean, it's great for the pediatric cardiologists, it's more jobs for them, but it is also causing lots of anxiety for the people, thinking when they have to wait to see the cardiologist, and then, complication, transportation and all that. So, the question number 1 is a preferred one if you are comfortable with that. Now, for your reference, I put, we discussed that case. It was a Stills murmur, but I'm putting here the other types of innocent murmurs. So I'll let you review this on your own when you have time, okay? So you will be available when you get the slides. So see, there are systemic flow murmur, venous murmurs. So 4 types of innocent heart murmurs. You can review them on your own. Okay, we go to a second case then. Oh, well, as a conclusion. Ideally, the primary care provider is comfortable after a thorough clinical evaluation in making the diagnosis of innocent heart murmur and reassuring the parents. In that case, an electrocardiogram is not indicated. False positive may increase the anxiety of the family, and we require a referral to pediatric cardiologists. So the level of comfort of the primary care provider depends on training and hearing capacity, and reassuring the parents can be a challenge. I want just to share with you what goes through the mind of the parent after you tell a mother that her child has a heart murmur. This is a study that was done, 20 years ago. So this is what they are thinking when you tell them, oh, don't worry, their child has a heart murmur. This is what they are thinking about. Oh, he's going to need medications now. Or 40% think he's going to be restricted from sport. A third think, gee, he's going to need cardiac surgery like my grandpa. And the 20% say, that's it. My other kids are going to have a heart problem too. And then, of course, some people are starting to blame themselves, something I did wrong during pregnancy. And of course, they are worried that the child is going to die suddenly, early. Okay. So that loss of anxiety. The other reason, of course, that people are so anxious is that heart disease is the #1 cause of death. So everyone has a family member who has died of heart disease. And then let's not forget that every case of sudden death in young athletes is reported in the media, And so everyone knows about that. Yes, you can die from heart disease when you play sports. But let's not forget also that the heart is the most important organ in the body. And let me tell you, this is not only what cardiologists believe. If you go back to ancient Egypt, back to Africa, where we all come from, all our ancestors were from there. After you die, this is what happened to you in ancient Egypt. You go to the Hall of Mat. And in the Hall of Mat, they put your heart on a scale. And on the other side, they put a feather. Now, if your heart is as light as a feather, then you make it into afterlife. That's great. But if your heart is, heavier than a feather, then this guy waiting for you here is some type of god, Amut. He eats you up. That's why that guy eats very well, because he has lots of food to eat. In any case, this is not only in ancient Egypt. If you look in the Aztec culture, the heart belongs to the individual, of course, but also to the sun gods. And the sun gods, they sacrifice themselves and fight against darkness every day, so man can survive. So it is obvious that in return, man must offer sacrifice to the sun gods. And the best offering sacrifice is a beating heart extracted from a live person through the abdomen, the diaphragm, and offered while still beating to the gods. Now, this is not the sun gods, it's another gods, but I like the colors. Now, this is not done anymore, but let's not forget, the heart is really a special organ. And you are reminded everywhere in the Americas, from Quebec all the way to the tip of South America, that the heart is a special organ, right? And then even if you go at different cultures, the heart is the organ where essential human emotions and virtue resides. The little space within the heart is as great as a vast universe. And it is only with the heart that one can see rightly what is essential, is invincible to the eye. So, the heart is really a special organ. Okay, let's go to the second case, otherwise we're going to run out of time. Arthur is an 8-year-old boy with scheduled for a routine well-child physical with you. And he has been followed by a colleague of yours. You review the chart and you see that he is overweight, has mild hypertension, and has had normal laboratory results, normal lipid panel and renal function. And Arthur was seen a year ago by a pediatric nephrologist. He was referred by your colleague to a pediatric nephrologist. And the pediatric nephrologist diagnosed mild primary hypertension related to overweight. So what do you want to document on this physical exam? Well, you want to take the blood pressure in 4 extremities, at least arm and legs, both arms and one leg. And what you see here when you do 4 extremities, there is a gradient between the upper and lower extremities, okay? In addition to that, you listen carefully and you hear a systolic ejection murmur at the base in the axilla and the back. So what's your diagnosis? Coarctation is suspected, okay? So you order an ECG and a chest X-ray. The ECG is normal. In mild coarct, it's always going to be normal. The chest X-ray shows rib notching and the 3 signs. So the 3 signs, is right here, like this, but most patients are going to have a normal chest X-ray. So most patients, unless it's very severe coarct and it has been going on for a long time, are going to have a normal chest X-ray and EKG often. But again, if you have hypertension with a difference between the pressure in the arm and the legs, you need to refer to cardiologist, no question about it. And the cardiologist will do an echocardiogram, and the echocardiogram will show the narrowing here. This is the ascending aorta, the aortic arch, and then with the color, you can see increased velocity in that area. So that will confirm the diagnosis. And then the MRI not only shows the coact very well, but also shows the collaterals. So not everyone would do this, because if you send it for a cardiac catheterization, they will have an angiogram, and that would show also the coarctation there. And you will refer for cardiac cath not only for diagnosis, but possibly for treatment as well, because you can put a stent there. So these are the two ways you can treat a coact: by putting a stent when you do a cardiac cath, or by doing surgery. So in summary, coarctation of the aorta is not terribly frequent, but it's very important for you as primary care provider to be aware of that condition, and always, the message: feel the pulse, to always, when you do a routine physical, in both arms, and then in one arm and one leg, okay? So people who have coact will have systolic hypertension in one or two arms and brachial femoral delay. And then they will have a systolic ejection murmur, usually in the back, in the base. If it is combined with AS, often they will have bicuspid aortic valve, so they may have a click and a murmur at the base. Okay. So the message here is to rule out coarctation of the aorta on any hypertensive patient, okay? Always take the pulse in both arms at the same time, then take pulse in the wrist and the stronger pulse in the lower extremity at the same time, looking for radiofemoral delay. Okay. So we have only a couple of minutes here to manage children presenting with symptoms, okay? And most children and adolescents presenting to your clinic with symptoms of chest pain, palpitation, of syncope will have a non-cardiac cause. For instance, according to one study, only 4% of children presenting with chest pain have a cardiac problem. Some other studies show even less number than that, 1%. So, every time you have chest pain, palpitation, or syncope, you need to rule out a heart problem. So how do you do this? Well, you do a physical exam. You take a family history, a history of the symptoms, and then you put it into those two categories, okay? If it is normal growth and development, no symptoms with exercise, no family history of heart disease, and the symptoms suggest a non-cardiac cause, like chest pain after eating, syncope during sudden change in position, palpitation during stress, normal physical and normal screening test, EKG and chest X-ray, then you can reassure the patients and the family and follow up in the clinic. However, if you have any red flags, symptoms with exercise, family history of early heart disease or sudden death, or suspicious cardiac findings on physical exam or an abnormal ECG, then at that time you would refer, do more testing and refer the patient for further evaluation. Okay, so we have 10 more minutes for questions, so I leave it up to you now. Jennifer, let me know if you have any questions.
Somebody wrote, in cases of syncope, how do you differentiate between cardiac versus neurologic causes?
Of what now?
A syncope?
Syncope. Oh, syncope. Yes, yes. Very good question. Okay. So it is always a red flag when you have syncope, but then you are going to ask questions, the circumstances, when did that happen? Okay. So if it happens just when people are standing up suddenly, or they have been, not drinking for a long time, or they have another illness, you are not going to think necessarily that it could be related to a heart problem. But again, if someone tells you they have syncope when they exercise, that is definitely a red flag and needs to be evaluated further. So if there is any doubt, it's not a bad idea to for syncope, unless it is typical when they just get up, quickly. I mean, getting an EKG is not a bad idea. You want to rule out, some of the things we mentioned, like the long QT syndrome and arrhythmia. But you can also ask them to keep a diary of the event, so you have a better idea. But if it is unclear, then it is reasonable at some point to have a further cardiac evaluation, an event monitor sometimes and things like that. Yeah. So again, it depends on the circumstances, but if you have syncope, like for sure with exercise, that would be a big red flag that needs to be evaluated. Syncope after palpitations, and if you have a family history of early cardiac death, all those things that we need further evaluation. Yeah. All right. Any other questions, Jennifer?
I don't see any yet.
All right. All right. Should we stop here, or do we wait until?
Did you have any more slides, or did you want to stay on this one
No,
and see
no,
if there's
no,
any more
no,
questions?
no. That's. I think I am finished here. Oh, okay. Well, actually, I am. Okay, that's a summary. Okay, most children who have a heart murmur have an innocent heart murmur and no structural congenital heart defect. Most children who have palpitations have anxiety and a normal heart. And most children who have chest pain have a non-cardiac cause for the pain. Most children with syncope have a normal heart and no significant cardiac rhythm problem. But before we, as primary care providers, come to that conclusion for our patients, we want to explore carefully to make sure we are not missing a cardiac diagnosis. Yeah, that was a summary. There are a bunch of references here for you, so I'll leave that for you. You can look at that. Okay. So I think that's it, Jennifer.
Hey, we do have one question. How
Okay.
do you take BP in the leg of a large child?
No, that's a good question. Well, hopefully in your clinic you have different size, you thing that you put around the leg. But I mean, you can try in the lower part of the leg if you don't have that. Instead of the thigh, you do it in the lower part of the leg. It may not work as well, but you can try. Yeah.
Okay, we can stay on and see if there's any other questions. I'm just going to read a few reminders that
Okay.
I did put this in the chat too, but just a reminder that the CME survey will appear in a tab when you close out of this webinar. We really appreciate you taking the few minutes to complete this. Not only does this give you CME credit, but also helps us to plan the best session for you. We share the feedback anonymously with the speakers, and they greatly appreciate your thoughts. And I also just want to remind everybody that to receive the CME survey, you have to complete that survey. So please make sure that you do. And it has to have your fill out the correct email address affiliated with your MAVEN project account with your correct licensure, and you have to have the correct date and speaker name. And while we wait for some more questions, I also put something in there about our mentoring program. We just wanted to remind you that MAVEN Project offers mentoring to all of our community providers at any point in your career. Some topic ideas to reference: new to practice providers, challenging case review, preventing burnout, building teams, and executive coaching. Also, we offer specialty specific mentoring like EKG or CGM, or reference the topic of today's ed session. So please reach out to us if you're interested in mentoring. And we'll stay on for a couple more minutes, see if there's any more questions. Still have about 2 minutes at the top of the hour, so while we have Dr. Rogé, please feel free to put any questions in the chat or the Q&A, or we can raise your hand and I can unmute you.
Uh, there are lots of sun in California, as you can see. I have to try to stay away from it. That's it then.
Okay, yeah, I think that's it. Thank you so much. Happy New Year to
Yeah,
everybody. And thank you, Dr. Rogé. That was a
yeah.
wonderful
Thank you,
session.
Jennifer,
Really
for your help.
appreciate you.
Okay, take care.
Have a great day, everyone.
Thank you. Bye-bye.
Bye.